Hey, good morning, everyone. I am Morgan, family nurse practitioner, joining you today. We have a lot of really cool stuff we're going to talk about. So if you ever have any questions, it's just going to be me this morning. Heva's going to pop in and out, but I am going to be here to answer any and all of your questions as we go through. So pop questions in the chat if you can, and that would be very, very helpful. And then if you have any questions, like as we're moving through, we can go ahead and just keep things kind of moving, and I'll try to get to your questions as soon as I can. Okay, so just a quick thing. We always like to talk about some of the new and cool stuff that we have available at Archer. So if you're not already following us on social media, please do. It's a really great way to kind of build community, ask questions to other people in your same boat. So if you're like an RN trying to become a nurse practitioner, or if you are a nurse practitioner or a student, all of those things you can go ahead and get in touch with each other through social media and on our Facebook groups. So please, 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 if you aren't already, go ahead and join. There's a QR code here. We're going to have lots of QR codes today. So go ahead. I know we never say this, but get out your phones because we are going to do some interactive stuff today to help you learn. I feel like it's just a really, really great way to keep you engaged throughout today's process. And it just is like the way that everybody answers questions really helps us kind of learn off of each other. So we're going to do that. We also have this package, guys, at archerreview.com. This is called SurePass Pro. As you can see here, it includes a lot of different things, including the QBank on demand, live, all sorts of really great stuff. So join there so that you can scan here to kind of look at some of the offerings we have. We do have just a free trial of our question bank that can kind of just give you an idea of what types of questions we write and help you kind of understand how to best prepare for your exam as you're moving forward. That SurePass includes the question bank. It includes on-demand videos. So that just allows you to learn at your own pace. You can pause, rewind, fast forward, whatever you want. And then we also do live reviews. So that's like an intense prep right before your exam to kind of cover all those topics really, really quickly, make you feel comfortable and ready. And then also we do have mentoring and tutoring available. So we would love to meet with you. If you want. And then I always say, we try to stay as up to date. This is my first time giving this lecture today. So this stuff should be all evidence-based and from the latest text and stuff like that. But I always tell people, if I'm speaking on something and you're learning something contradictory in school, let us know because we really want to make sure we're always giving the most recent and up-to-date stuff. And, as you're in school, you're probably learning a lot of that new stuff. So Nurse Practitioner Archer Review, if you have any questions, you can always reach us there. Okay, let's go ahead and just practice with this. This is going to be our way to kind of interact and talk with each other today. I think that people love it. It's completely anonymous. So go ahead and scan this QR code. I'm going to activate it here. Scan this QR code if you can. I'm going to do it too, just to make sure it's working. And go ahead and just let us know where do we have people joining from today? I'm going to put mine in. I'm in Denver, Colorado. It is so chilly. It's snowing as we speak. Florida, awesome. Okay, I'm in Denver. You're in Florida. Hopefully the weather's decent down there in Florida. But what I'm going to have you do, guys, is we're going to go through an entire case study today. And I'm going to have us answer questions. We're going to think through the differential diagnosis. We're going to think through testing. We're going to think through medications. And that way you're really, really participating. Awesome. Okay, Illinois, Indiana, Connecticut. Great. Okay, are you guys all ready to participate? I appreciate it. It makes it more fun when we're doing this together. If I'm just talking to to infinity, it's not as fun. So I appreciate you guys pulling up your phones and working with me here. Okay, we are going to jump right in. The Slido is working, which is good. And we are going to talk about um, our uh, um, gastroenterology and the medications, really focusing today on antacids, all of those acid reducing agents that we have, how they work, why they work. And then we're also going to talk about H. pylori treatments because H. pylori is tied so closely with those. I thought it would be good to go over those. And then lastly, we'll finish up with a case study. I have lots of questions for the case study, so hang around if you can. And as I said today, if you do have questions throughout, go ahead and throw them in the chat, and I'm going to do my best to kind of manage both of those things. Okay, now let's just do a quick review over our pathophysiology of hyperacidity or acid reflux. Okay, so GERD, also known as gastroesophageal reflux disease, this is a common condition that affects the stomach and requires drug therapy oftentimes to help. Now, depending on what drug therapy we use, it's kind of a step up. A lot of your patients you're going to see have already tried some of those basic things. There are so many people who are afflicted with this, it can come and go. So it's going to be something that I want you to feel confident in your prescription authority and what to do at your next step. Okay, so essentially, what is happening in GERD? What we're really talking about here when we think about GERD is we think about hyperacidity or high acidity. The stomach is producing too much acid. And why we care about it is if we leave this untreated, we can have things like just acid reflux, right? That really nasty kind of heartburn pain. We can also develop ulcerations in the stomach and the duodenum. We can get esophageal damage. Okay, so we start actually seeing damage, and left untreated in some cases, more severe, this can lead to something like esophageal cancer or changes in that cellular lining. Early signs, Barrett's esophagus. You may have heard that before. All right, so before we talk about the treatment, let's quickly just kind of review this pathophysiology this of the stomach. So understanding this, kind of how everything works, is going to help us understand how the medications work to relieve our symptoms and protect patients from further complications. All right, so breaking down the stomach's functional areas, we're going to start with, the stomach is one organ, but we divide it into three functional areas, and each of these areas contains specialized glands that secrete different substances. All right, so we're going to first talk about the cardiac glands. These guys are located near the cardiac sphincter or the gastroesophageal sphincter, so up here in this region. Then we move down into the gastric glands, which is found really in the fundus, which makes up most of the stomach's body. Finally, we have the pyloric glands, and these guys are located in that transition point between the fundus and the pylorus. Okay, among these, the gastric glands are really going to be the most specialized, and they contain several different types of cells that really play a key role in our acid production and digestion. The three most important cells that we think about especially when we're thinking about acid production, we think of the chief cells, the mucus cells, and the parietal cells. All right, they have their key functions in acid production. So let's go over which each of these do. All right, the chief cells, and this is just a brief review. I don't expect you to memorize all of this. Just kind of start thinking about this pathophysiology. But these chief cells, they secrete pepsinogen, which is that inactive enzyme. And when it comes into contact with the stomach acid, it activates into pepsin, which is an enzyme that breaks down proteins. Okay, so chief cells, pepsinogen to pepsin. Then we move to the mucus cells. These guys produce mucus, and they're really designed to protect and coat that stomach lining so that the acid that we're producing in our digestive enzymes don't digest our stomach itself. Finally, we have those parietal cells. These are the big key players that I want you to think about when we're thinking about that acid production. They really secrete that hydrochloric acid or HCl, and they do it in response to food. So whether it's the sight, the smell, the taste, or actual presence of food in your stomach, those parietal cells are going to start working. And they have really three key receptors on them that control acid production. We have the acetylcholine receptor, the ACH receptor. We also have histamine receptors, and then finally gastrin receptors. When any of these receptors are stimulated by their respective signals, so acetylcholine, histamine, or gastrin, that parietal cell will get activated to start producing acid. All right, so this is where our medications come in. They really target these different receptors on the parietal cells to reduce acid production and help manage our GERD symptoms. Okay, in this next part, we'll kind of just take a look at how these different classes, like the proton pump inhibitors, H2 blockers, intervene at those receptor sites to block it and help our patients feel better. All right, so here's just another look. Our amazing team, if you saw that stomach glands and this one, our amazing team and medical illustrators here at Archer have worked so hard to create these. Thank you guys so much. Super helpful to help you kind of understand and be able to see a little bit more about how these cells work. All right, so first up, we're gonna just take a look at that parietal cell. When receptors land on the cell surface, they become occupied, they're going to send a signal inside the cell. In this case, we think of, first up, histamine receptors. This signal leads to the production of an enzyme called adenyl cyclase. What does adenyl cyclase do? Adenylate cyclase do? It's really going to help converts ATP into CAMP, or cyclic adenosine monophosphate. Okay, so CAMP is the energy source that kind of fuels our proton pump. Okay, so what's the proton pump? It's a transporter located in that parietal cell of the stomach, and its job is to move hydrogen ions. Okay, so we need hydrogen ions to produce hydrochloric acid. So we have a proton pump that needs the energy function. And so what it does is we can go ahead and block that production of energy through blocking the adherence of those transmitters to the receptors. So we're kind of blocking through these different mechanisms using these different ideas that we have on this parietal cell. Does that make sense at all? Okay. It looks okay. Just looking at the chat, just making sure we didn't have any questions between those things here. Okay. Now, let's just take out our phones one more time. I know we don't often tell people to take out their phones. Take out your phone. Go ahead. You can scan the QR code here on the phone. And the question that I'm asking here is, what are some medications you are already familiar with in the treatment of acid reflux? And there are a lot. So go ahead and let me know, what are some of the medications that you're familiar with? Just list them all off for me. Okay.
Morgan, I think you have to activate this one.
Oh, let's see here. Oh, it's coming on.
It's probably just on my end. I apologize.
Oh, okay. No worries. Thanks, though. Thanks for letting me know. Okay, Protonics, Pepcid, Prilosec, Zantac. Yes, absolutely. Anything else? These are brand names, so we're going to talk brand names. We're also going to talk of the generics. Tagamet. Okay. What else have you guys seen used? Have you used, your families? Pepcid and omeprazole? H2 blockers. Yeah, I love that class of drugs. Any other classes that you can think of? All right, you guys are awesome. I am going to move on here to our next slide. Thank you so much for participating. You guys are so great. Okay, so when we're talking about these different classes, these different drugs that we can use for acid production, here are a few different classes. This is what we're going to get into today. Okay, so we think of options like antacids, Tums, right? Those work relatively quickly, neutralize our stomach acid. We have the H2 blockers, such as famotidine, which really work to reduce stomach acid production through that H2 blocker. We also have our proton pump inhibitors. That's something like omeprazole, which, a little bit stronger, help a little bit more with some of those persistent acid issues. Then we get into some things like a protectant. So sulcrophate is something that we can use to protect the stomach lining. We also have prostaglandin analogues, so misoprostol, which you may, if you've ever worked in OB or has been a patient, you may have heard of this. It's also known as Cytotec. We have GI stimulants, so things like Reglan. All of these different things kind of help move the Reglan helps move food through the stomach a little bit more efficiently. So kind of getting that acid kind of going through the stomach. So we have all these different classes. So let's dive in. First up, antacids. Really common, probably the most common over-the-counter remedies for acid-related discomfort. So what are they? These are basic compounds that really work by neutralizing stomach acid. They provide quick relief from symptoms like heartburn, gastritis, or hyperacidity. Okay, most of them contain some sort of salt, aluminum, magnesium, calcium, sodium, and these ingredients have been used for centuries to help with acid-related issues. Okay, so when do we use them? We use antacids typically for acute relief of symptoms. If somebody has like a peptic ulcer, gastritis, again, any sort of heartburn would be really great. And how do they work? They work very, very simply. The mechanism of action here is pretty simple because these are basic compounds. What they do is they neutralize that stomach acid, making it a little bit less irritating to the stomach lining, and that esophagus really works to reduce some of that burning discomfort that we see. And it's pretty quick. Okay. So the next time somebody reaches for their antacid, they're using a very time-tested solution for managing their acid-related issues. This is something that's been around for a very, very long time. Okay, we've known about this as a very great way to use it. You can see here our contraindications, obviously, for any of the medications we ever talk about. If somebody has an allergy to it, we're probably going to really consider if that's something we're going to prescribe or not, right? There are things like in chemo drugs where we might have an allergy to a binding agent. However, they might pre-treat. But in most cases, very, very oftentimes, if there's a known allergy, we're not going to prescribe it. If somebody has severe renal failure or a GI obstruction, we're not going to go ahead with this. All right. Like I said, renal disease, we're going to use caution in these medications. All right, moving on, H2 receptor antagonists or H2 blockers. These, again, probably some of the most commonly used medications for acid-related conditions, especially when we start thinking about peptic ulcers, acid reflux, really, really popular and popular for a good reason. They're very effective, they're well tolerated by most, and they have a pretty great safety profile. Okay, so how do H2 blockers work? Well, we talked about those different sites on the parietal cell. So the H2 blocker will compete with a histamine, for the H2 receptor in the acid-producing parietal cells of the stomach. So by blocking these receptors, the parietal cell becomes less responsive, not only to histamine, but other stimulators of acid secretion like the acetylcholine and gastrin, which then equates to less stomach acid production. The pH will go up, and we're going to see some relief from some of these different types of symptoms that a patient might be experiencing related to overproduction of the stomach acid. So some of the most commonly used H2 blockers include things like cimetidine and famotidine. We used to have ranitidine. It's been pulled off the market due to stomach cancer risks. So we no longer are using that. That was very common back when I was first studying, but no longer are we using that. So just something to know. These are all available over the counter. And when it comes to effectiveness, there's very little difference between those two medications. Okay, so we have Zantac and Pepcid. Overall safety, very well tolerated. The side effects occur with less than 3% of patients. That being said, I do want you to use caution in older adults as they can have some central nervous system effects like confusion or disorientation. Okay, it's very rare. And it's not a direct contraindication. It's not something that we can't use in an older person. However, I want you to know that that can be a side effect that we would want to be watching out for if we're prescribing it. Cimetidine in particular in the last, it has a few unique side effects. It can cause an impotence, gynecomastia, and that's because it interferes a little bit with estrogen metabolism and can disrupt a little bit of our androgen activity. So just something to note. And I would guess that's with long-term, multiple uses for over a period of time. If you're using it kind of as needed, it would be okay. All of the H2 blockers can increase prolactin secretion. Remember what prolactin does. Prolactin encourages milk production. So just something to think about. And then famotidine has been linked to stuff like thrombocytopenia. Again, not very common, just something we need to know when we're thinking about prescribing it. We consider kidney function and liver function, just may require some dose adjustments based on those things. So always be looking at your monitoring parameters and dose adjustments based on renal and liver function. Of course, the only absolute contraindication here, again, is the known allergy to the drug. Bottom line, the message I want you to kind of take, H2 blockers are really a great option for managing acid-related conditions. But like any medication, they have to be used with awareness of these potential side effects and use your judgment and patient specific considerations when we're considering these as an option. I just wanted to give you a quick look here. Another great design by our Archer Med Illustrator team. But these are the sites that histamine works on. Okay, so we have it in our stomach here, but we also see dilation of small vessels. We can notice that it can increase a little bit of our capillary member permeability, which can lead to things like edema. And as we said before, that kind of central nervous system effect, right? We know it's an H1 and these guys are H2 blockers, but they can have some activity on these cells. And that's why we're very, very cautious in elderly people when we're prescribing these. Okay, any questions up until this point? Great, let's keep it up. So next up, PPIs, proton pump inhibitors. These guys end in the prazole ending, just super easy to kind of remember the class of drugs using those endings. But these are a favorite, right? They work very, very well. We consider these kind of the big guns when it comes to reducing stomach acid. They really work by directly binding to the hydrogen potassium or the ATP pump, also known as the proton pump. Okay, these are irreversibly binding things. So it is shutting it down. This is a complete and total blockage of hydrogen ion secretion from that parietal cell into the stomach. All right, so this significantly will reduce stomach acid production in the stomach. And like I said, it's an irreversible connection there. So once it's bound, and now we have kind of disenabled that pump, and so we have to recreate new pumps in order to reproduce acid. So let's go over these guys just a little bit and how you might see these used in practice. So we have the Prevacid, lansoprazole, omeprazole, pantoprazole, lots of different azoles that we use, okay? And their brand names you can see are right next to it. I like using generic names when I'm talking because it gives us the idea of what the class is. So if you say Prilosec or Pepcid, that can be very difficult. Which one is it from which class? But if we say omeprazole versus famotidine, we know exactly which class we're talking about. And so get used to, and you can use Google pronunciation and stuff like that. And I know my pronunciation isn't always great, and people do say these words differently. So go ahead and just practice how you feel comfortable saying them, but make sure you know these endings because it will definitely help you moving forward. All right, the PPIs are considered our first line therapy for several conditions, including erosive esophagitis, symptomatic GERD that doesn't respond to H2 blockers. We also use them as short-term treatment if we have an active duodenal or gastric ulcer. And then if we have some hypersecretory conditions like that Zollinger-Ellison syndrome, if somebody's using heavy doses of NSAIDs, maybe for arthritis pain or short term after a sprained ankle, and they're at risk for something like a GI bleed, we go ahead and put them on a PPI to protect their gastric lining. And then stress ulcer prophylaxis. Okay, so if somebody is going through a really stressful period in their life, we can consider, and they're having that kind of early pain, we are thinking they're at risk for developing a stress ulcer, we can go ahead and use something like a PPI. All right, so here's the point. The PPIs reduce acid secretion by more than 90% over 24 hours, which means most patients become temporarily like low hydrochloric acid production. Basically, they have little to no stomach acid when we first start this, okay? While this is really, really great for treating these, it does come with some risks, okay? So the risks include just bacterial overgrowth. We have now disrupted our pH in our stomach, so we can get and see different types of bacteria kind of taking over, intestinal metaplasia, and even an increased risk of hip fracture. So something like osteoporosis is a risk factor, long-term use, okay? The good news is that food absorption really doesn't seem to be significantly affected. Kind of blows my mind when we get somebody to such a caloric, you know, a really low acid state in their stomach, we're still able to digest food in that state. So, our body has kind of some of those backup fail-safe mechanisms, and that's what's going to occur here. All right, so what happens when a patient stops the PPI? Acid secretion doesn't snap back immediately. The parietal cells actually have to synthesize those new pumps. Remember, we had that binding that is irreversible. Interestingly, though, there are proton pumps in the body, that exist only in the stomach cells. That means they're really, really specific to gastric acid secretion, making them very effective. But we just don't have a lot of adverse side effects. So they're pretty good. These are powerful, widely used medications. Again, we did talk about some of those risks. So we want to make sure that we're monitoring and educating our patients of the risks when we start using these medications. My guess is if you're coming into a primary care role, you may find that patients have been on these medications for a long time. And there's always a conversation around why and if we can decrease the frequency of use or taper them off and start something else. But I always like to do a slow taper when we do this because there is a phenomenon called rebound acid reflux that can happen. So I never stop a PPI from one day to the next. It's definitely a gradual taper, usually about over 4 weeks, with the use of something like famotidine for any sort of breakthrough while we're on the PPI taper. Okay, questions there. I know that's kind of a big one that we talk about. Oh, I got somebody asking. Okay, we'll get that one. Okay, next up, this is an interesting one. This is called Carafate. I actually have one patient who's on Carafate kind of continually, and it's an interesting thing. This is a GI protectant. Sulcrafate is the generic name, so just making sure again that you realize what that means. Sulcrafate is a mucosal protectant. It really helps shield the stomach lining, primarily used to treat things like an active stress ulcer. Really, it can be used as that long-term therapy option for somebody with peptic ulcer disease, somebody who's getting a lot of ulcers. This could be somewhat kind of preventative. Sulcrafate acts locally, not really systemically, meaning it works right where it's needed, okay? Right at the site of that ulcer. So when it comes into contact with stomach acid, it breaks down into aluminum hydroxide, which is an antacid and sulfate ion. And the aluminum salts really help stimulate the production of both mucus and bicarbonate, which are essential for protecting that stomach lining. Okay, the real magic happens when that sulcrafate binds to the ulcer itself. Its sulfated sucrose molecules are really naturally attracted to the positively charged protons that we might find at the base of an ulcer or erosion in that stomach lining. So it forms a protective barrier, almost like a liquid bandage you can think of, shielding that ulcer or that exposed area of the stomach to the acid and really prevents any further damage. All right, so it helps limit that pepsin activity. Pepsin is that enzyme that breaks down proteins, which is great for digesting foods, but not so great when it starts breaking down our gastric tissues, making those ulcers worse. The drug also really binds and concentrates to epidermal growth factor, which will help promote some of that healing. It stimulates prostaglandin secretion, which also has this protective effect on our stomach. Now, despite all of these benefits, sucralfate really isn't used all that often. And really, because the effects are kind of short-lived. So when we think of something that's short-lived, what do we think about when we think of patient adherence? Any ideas? When I think of something being short-lived or the action being pretty narrow, I think of multiple doses a day. These guys can be used up to 4 times a day, and that's a lot, right? That can be really challenging for our patients to adhere to a regimen in which we're requiring multiple doses a day when we have something like a PPI that's once a day dosing. But it's still used, it's indicated for the stress ulcers, peptic ulcer disease, any sort of erosion happening. And really, the only contraindication is a known allergy to this drug. Side effects are relatively uncommon. We could, see things like nausea, constipation, maybe a little bit of dry mouth. But like I said, that systemic absorption is pretty minimal. So overall, this is a fairly safe medication. Drug interactions, the biggest thing I think about with sucralfate is that we can have a little bit of interference with the absorption of other medications. So we typically say, and again, this goes into our adherence, we say like, it's better to avoid this medication. We don't dose at the same time. We don't take this medication at the same time of others. We say to take the other medications at least 2 hours before we dose the sucralfate. Again, just makes that adherence a little bit harder. Okay, now that's all I've got for sucralfate. So let's keep moving on. Next up is this prostaglandins. This is an interesting medication. I've actually never seen it prescribed for this indication. I worked in OB nursing inpatient for almost 9 years as a labor and delivery nurse, and we use this medication all the time in labor and delivery because it causes cervical ripening and uterine contractions. So that is just going to get us right into what we don't use. I'm just going to let you know we never ever prescribe this in a pregnant person because it is an off-label use is for inducing labor. Okay, so Cytotec is another name for this medication. Misoprostol is the generic. It is a prostaglandin E analog, and it's primarily used to help reduce the risk of gastric ulcers in patients taking NSAIDs. So you have an older male patient, maybe who's on chronic NSAIDs. This could be an option for you. Again, I don't see it used too often because we have things that are like the PPIs that are just a little bit better, but you should know about this medication. So prostaglandins really help us protect our stomach lining by reducing gastric acid secretion and enhancing the production of protective mucosal and mucus and that bicarbonate. So kind of offsetting the acid content in the stomach. They also promote kind of local cell regeneration. They maintain mucosal blood flow, which really helps keep that stomach lining nice and healthy. There are we already talked about how this is contraindicated in a pregnant woman because it can cause uterine contractions, leading to things like miscarriage or preterm labor. And then also, if you have an allergy, we won't prescribe it. Okay, common side effects with this: headache, GI distress, might have some nausea, diarrhea. If you are a female, even if you're not pregnant, you could experience some vaginal bleeding. Okay, we don't see a lot of drug interactions here. Might reduce, a little bit of absorption with some different medications. We think of synthetic prostaglandins can also really help heal duodenal ulcers. The side effects, like we see abdominal cramps, diarrhea, can be pretty bothersome. And because of this, that's why we don't quite use it as often. Most people, they just don't love the feeling. The dose is typically 200 mics 4 times a day, again, with meals. So you're thinking about adherence. You're thinking about how often do we have to prescribe this? Um, and again, 4 times a day, it's a lot. We're asking our patients a lot when we're trying to do this. So that's kind of why we don't typically use it, but just to know that it's out there, it's something that some providers may use, especially if somebody's not responsive to other things or have other contraindications to different medications. Okay. Lastly, our final antacid that we're going to talk about, this is a prokinetic agent. Prokinetic meaning that it helps move through things through the GI system. So Reglan is the medication that we see often. We see this also come up in an anti-nausea arena. But when we're thinking about it in this hyperacidity state, we're going to go into here, but we do see this Reglan used a lot in somebody with nausea. Okay, this medication really works by promoting that movement of substances through the GI tract. Okay, it increases motility, therefore, it's just pushing things through. And we can use it for conditions like delayed gastric emptying, esophageal reflux, and like I said, an antiemetic, so nausea and vomiting. So it's available by prescription only and for good reason. If this is not used correctly, it can cause some pretty serious side effects. Okay, some people should completely avoid this medication, including anybody with like a seizure disorder, um, breast cancer, a GI obstruction, right? If somebody is obstructed, we don't want to start pushing medication that's going to increase motility. And then obviously, if we had any known allergies, and allergies also to procaine or to procaine, so just something to look up. It comes both in our oral and injectable forms, but one of the major concerns, especially in young adults, is the risk of extrapyramidal side effects. So if you have anybody at risk, so seizures, we're definitely not going to prescribe, but in younger folks, we really don't want to choose this. The FDA in 2009 actually issued a public health advisory about this for the potential for developing tardive dyskinesia. So with more long-term use, we can see a little of those EPS type things. We have better options. So if you're using it for the reasons here, I really strongly urge you to consider, is there something else that might have less side effects and be more appropriate, especially in younger folks? It can be effective. We need to use it very closely under close supervision. And again, just really weighing those risks versus the benefits of this type of medication. Okay, so that wraps up the first portion. Now we're going to get into H. pylori. Before wrapping up here, do you guys have any questions about what we've talked about so far? Okay, I'm going to keep my chat open here. So if the questions come up, please feel free to reach out, but let's keep moving. So H. pylori, I'm going to go over a little bit of our pathophysiology here as well. This is a bacteria that lives in the stomach, and believe it or not, it's found in about half of the world's population. Okay, very common bacteria that lives in our stomach. Most people who have H. pylori, they don't know it's there. They don't have symptoms, and they never develop any issues. But for some people, this bacteria can lead to digestive problems, can lead to things like ulcers. In rare cases, if left untreated, maybe be putting us at risk for stomach cancer. So the question is like, why do some people get sick while others don't? We don't fully understand that yet. All right, this is a question that we keep asking ourselves, and maybe someday soon, hopefully, we'll know why is it that H. pylori and is fine in some people and not in others. Okay. H. pylori is usually spread through food or water that's been contaminated. Okay, so we think of fecal oral a little bit when we're thinking about this. So it comes in contact with a fecal matter from somebody who's been infected. And once inside, so feces to oral, once it's inside our stomach, it can, like I said, not always, can disrupt that protective lining, can trigger inflammation, it can release toxins and enzymes that actually lead to mucosal damage. All right, this can cause conditions like gastritis, which is just inflammation of our stomach lining. It can cause inflammation in the duodenum. which is that first part of the small intestine. And then over time, these changes really can make the stomach lining more vulnerable to digestive acids. So we have caused this kind of disruption in the entire mucosal lining in the stomach, which puts us at more risk for other things like ulcers. Okay, so who's at risk? Well, being that H. pylori is super common, people at risk for complications from H. pylori typically are older adults. Around 40 to 60% of the people over 60 have it, compared to like 10% of those under 30. When we look at ulcer patients, H. pylori is found in about 90% of people with duodenal ulcers, and about 70% of those with gastric ulcers have H. pylori present. So here's the interesting part. Many of those people, like we talked about, who have H. pylori don't ever develop ulcers at all. So it tells us that ulcers likely have like a multi-module cause, right? It's not just the H. pylori's presence that causes the ulceration, but something else is at play along with H. pylori, kind of allows H. pylori to kind of take over and really, in the right setting, will cause something like an ulceration. So why is H. pylori important? Well, it's really, really important when it comes to like that stomach health, right? So we really want to make sure. Okay, and then here we have a little bit of our testing that we can do and our symptoms. So just a quick review here of the different areas. So duodenal or gastric ulcerations, pain, bloating, feeling full quickly, decreased appetite, dark stools if we had bleeding. And then we have testing that we have the breath test, stool test, we can do a biopsy. Not too often, but sometimes people will draw an antibody in the serum. Okay, not the most common, but this is just a little bit of some information there to talk about. So what do we do about it? So H. pylori treatments, we have two pretty typical options. So we have triple therapy and we have quadruple therapy. I like to remember these as the triple is PAC my ulcer, so PAC, proton pump inhibitor, amoxicillin, clarithromycin. And then the quadruple is treat my belly pain, TMBP. Okay, tetracycline, metronidazole, the bismuth salts, and PPI. Okay, so just a little acronym to remember those. So let's get into it. The American College of Gastroenterologists recently published guidelines for H. pylori infection, and they told us, this is a change in my practice since reading this, that the first line treatment is going to be quadruple therapy, okay? Consists of a 10 to 14 day course of the following. Okay, so 10 to 14 days. And then that PPI is going to go on longer while we're protecting that gastric lining and trying to heal that. The PPI will be continued at least 4 weeks with a taper. So typically around 8 weeks of the PPI. Okay, one thing that we really want to think about. So our options include PPI, clarithromycin, or an amoxicillin or metronidazole. Okay, so we can get either one of those. Metronidazole or amoxicillin can be used here depending on allergies and stuff like that. Another combination is the PPI with the bismuth salt, tetracycline, and metronidazole. There's lots of different ways we can combine this, but what we're talking about is we're using 4 different types of medications, 2 antibiotics, the bismuth salt, and the PPI. The antibiotic choice is going to be really differentiated because of allergies, possibly, to these different things. As you saw, and we'll compare here to the triple, it's also 2 antibiotics. So it's always going to be 2 different antibiotics. What do you think of when you think about giving somebody 2 antibiotics for 10 to 14 days? What are you concerned as like a possible kind of side effect from that heavy course of antibiotics? Anything come to mind here? You can put it in the chat. Sorry, I don't have this as a Slido question, but just something that came to me as we're talking. So what I think about when I'm worried about giving such a long course of antibiotics is the risk of C. diff. Okay, so it's a good question. If somebody has like really severe diarrhea, watery diarrhea, possibly blood in their diarrhea, and they have been on something like a quadruple therapy or triple therapy for H. pylori, that's a common thing that we would see. I like using probiotics when we're considering something like an antibiotic use this long, and you can actually use probiotics at the same time as taking the antibiotics to prevent something like a C. diff, even though you feel like you might be counterproductive a little bit. It might help with those lactobacilli kind of, at least every day maintaining, or eating things that are like probiotic in nature, fermented foods. You have your kimchi, or kombucha, yogurt, stuff like that, that can be very, very helpful in preventing something like C. diff happening. I always tell patients go ahead, take your antibiotics with food to prevent some of that stomach upset. We think of tetracycline as that risk for teeth staining, not to give with calcium, and make sure plenty of water to avoid some of that esophageal irritation. There's this kind of mixed, body of evidence as far as antibiotics and birth control, oral birth control. So something, just maybe use a backup in the meantime, to prevent something like a pregnancy from going forward. All right. Last option here, or another option, like the most two common, would be our triple therapy. This is what we typically used up until, I want to say, in the last year. That is when that quad therapy as our first line came out. So triple therapy, we're still using two antibiotics. The only thing we're not using here is going to be the bismuth salts. Okay, they think that it's a very critical thing to help heal the ulcerations. That's why the evidence has shifted to include something like a bismuth salt. Okay, so if we have a penicillin allergy, obviously we're going to use metronidazole. Again, that's the same thing in our quadruple therapy. We can use amoxicillin or metronidazole, and then clarithromycin or tetracycline. It's like that big difference to think here. Indications, again, H. pylori. All right, and the same risk factors when we're thinking about C. diff. So I like using probiotics. It can be very, very helpful as far as the PPI goes. So this is just something to consider, is a slow taper to really avoid anything like rebound acid reflux. So the way that I think about this is, when I'm prescribing a PPI for somebody with H. pylori positive and symptomatic, when we think they have a little bit of ulcer, but no red flags here. What we're going to do is do 4 weeks of a PPI daily use. And then at 4 weeks, I'm going to go ahead and slowly taper. It might look like, if I had them on 40, I might go ahead and cut it in half, cut that dose down to half. If it's an extended release, then you need to make sure that you're actually sending in a new prescription. You can't cut those types of tablets. And making sure you can go ahead and decrease that, and then going to 20, from 40 to 20 daily for about a week, and then going to 20 every other day, and then 20 every other day, and then off. I like using famotidine as kind of an intermittent for any sort of breakthrough, or they could go ahead and use Tums over the counter if they're having breakthrough, depending on how severe it is. And then I like getting a test of cure. So after H. pylori treatment, we're going to go ahead and do a test of cure. But in order to do a test of cure, we need folks to be off of their PPI for at least 2 weeks. Okay, so a PPI can actually really, really kind of inhibit and cause a false negative, because it's going to of the H. pylori testing. So they have to be off of the PPI for at least 2 weeks before we're getting a test. So let's just reverse this really quickly. So say somebody comes in and they've been treating themselves with over-the-counter omeprazole, and you are suspicious for something like H. pylori and an ulcer based on your exam and their findings, your exam findings and their story, right? Their HPI. We're thinking that this is, but we can't test them today in the clinic for H. pylori if they have been taking a PPI in the last 2 weeks. So what we would do, my course of action here would be to go ahead and do a pretty abrupt off the PPI, which, it's not great, but go ahead and give them a high dose of an H2 blocker. Famotidine is my go-to. Give them a high H2 blocker to kind of help, and then get them in as soon as possible for that H. pylori testing as soon as those 2 weeks hit. So I'm like, if you're up for it, We can do a slow taper off of this, but that prolongs kind of our treatment options. If you feel comfortable just knowing that you're going to have you could have some bad days ahead, but we can, use max dose H2 blockers to kind of get that under control, but get you in for that lab testing in 2 weeks. So the breath test, get you in for that right away and go ahead and treat for H. pylori if it comes back positive. The same thing goes for our test of cure. I don't want to test right when they come off that PPI. I need to wait at least 2 weeks. So I'm not getting a test of cure oftentimes till about 10 weeks after initial treatment was started. I like getting a test of cure because there can be some resistance to these treatments. And that's why we're kind of stepping up to things like the quadruple therapy and so forth. So making sure that you're having those conversations. Okay, you guys, that is it for this. Now it's our case study time. I love case studies. This is how we learn together. So I appreciate your participation. There is no such thing as a wrong answer. It helps us all learn. I recently heard, I think it's like, maybe it was Benjamin Franklin who said, I didn't fail. I found 10,000 ways that don't work. And that is how I want you to think about this. Okay. I really don't mind if we have answers that maybe just feel confident, just put what you have in your mind and let's participate and try to get this going. Okay, so we have a case study. I'm going to just read it to you really quickly, the highlights. Alex, he's 29-year-old cis male, otherwise really healthy, he's athletic, blood pressure, everything, vital signs, great. Family history there, but otherwise he's healthy. Does have a family history of gastric cancer. We should note that. Okay. He's got some burning epigastric pain, started about a month ago, and it's worse on an empty stomach. Oftentimes improves temporarily after eating, but returns within 1 to 2 hours. Reports occasional nausea and bloating, denies unintentional weight loss, so he's doing oh good, not throwing up blood or having any red stool or anything like that. He has been taking ibuprofen for the last 2 months due to some back pain from a sports injury. So pretty heavy dose of the NSAIDs. Doesn't smoke, drinks a few beers on the weekends, and no history of acid reflux. Okay, your exam findings, we found mild epigastric tenderness to palpation, no guarding or rebound tenderness, no signs of anemia, normal conjunctiva, and you did a stool test just to make sure, and there is no blood. He told you there's no blood, you confirmed it. Good job. Okay, so we are, if you haven't, you can go ahead and pull out your phones, and let me just activate the next question here. Okay, so based on what you're seeing, what is the most likely diagnosis? Any ideas? What are you thinking for a diagnosis? And anything, right? Like, what are things that we're ruling out? What's something that should be on your differential? Ulcer from NSAID use, absolutely, 100%. Anybody else? H. pylori, great. Yep. Peptic ulcer disease, great. Gastritis, awesome. Anything else? Any other things that you could have? Just differential. What things are on your mind? Okay, let's keep on moving. Okay, now back over here. We're going to give him the diagnosis of peptic ulcer disease, all right, based on kind of what he saw. So, our rationale, we have that burning epigastric pain that improves with food, returns within a few hours. We had that chronic NSAID use, which increases the risk of ulcers. No history of GERD symptoms. He hasn't been experiencing this for a long time. And risk factors, like we said, are all of these guys. We might have some H. pylori, okay? And alcohol consumption can exacerbate this. All right, so what are the preferred methods for diagnosing an H. pylori? What would you maybe consider getting as far as tests? So let me go to our next question here. Any ideas? What test might you order for H. pylori? We talked about a few different methods here. Anything that comes to mind? The breath test, yes, absolutely. That would be my go-to. He didn't say he'd been using anything, so we can go ahead and get that in office today. at my office, we could do it in office. A stool test absolutely would also work. Anything else that we could consider doing? What if we were really worried about him? What if he had weight loss? What if he had a positive um, hemocult test? What might we do then? Yeah, okay, like it, good. What's the one test we might consider? Okay, I like it. CBC, CMP, iron studies, ferritin. Awesome. Love it. GI for scoping. Exactly. You guys are so good. You are on the right track. And this is what I want to see. This is how we learn all these different tests. And if there's anything that you guys are seeing on here and you're like, well, what is that test? Write it down and go look it up afterwards or give us a call or an email and we'll help you. EGD, yes. Good job. You guys are awesome. Okay, let's move on to our next question here. Okay. Oh, just a quick rationale. So here we have our preferred methods. You guys hit all of them. So really, really good. Again, we talked about that 2 weeks off of a PPI because PPIs can suppress that H. pylori and give us a false negative. All right. And we want to discontinue those antibiotics and business for more than 4 weeks before testing. So if we're doing a test of cure, and then an interpretation. So if it's positive, it tells us that there's something going on there. All right, our next question here. Let me go over to this guy and send it. The next question, what next steps should be taken for testing to ensure accurate results? We kind of talked about it a little bit. Oh, wait, I think that was kind of on our last one we talked about. That's just like getting off the PPI. Yep, good. And the antibiotics, if they had been on antibiotics recently. Okay, that was that question. Okay, next up, one other question. Oh, somebody's part typing. Stop antibiotics. Yeah, great. Good job. Okay, next question I have for you. What are some key differentiating features between peptic ulcer and GERD? So when we think of just acid reflux versus an ulcer, what are some differences that you would think about? Anything come into mind? How food affects pain, 100%. Really good. And then depending on if it's gastric versus duodenal ulcer, then that time of pain and food might change as well. Timing, yes. Better or worse with eating, 100%. Yep, good. All right, and somebody else is typing. A couple people are typing. Yes, exactly. Yeah, we're gonna have that epigastric pain, positional pain during sleep. I love it. You guys, this is really, really great. So what I've got for you here is when we think of pain pattern associated symptoms in etiology, this is kind of what we think about a little bit. So we're really thinking the etiology with an ulcer. I should add stress here. I think stress is also really important. But we have a lower esophageal sphincter dysfunction. Okay, for some reason, it's just not doing its job. It's not holding food down. Obesity is a big risk factor, diet, stuff like that. We think of heartburn, regurgitation, chronic cough, dysphagia. Here we think of more nausea, bloating, possible GI bleeding, stuff like that. Worse on an empty stomach, worse after meals. Relieved with food but returns later. Okay, that's what everybody was talking about. Versus this kind of gets worse right after we eat, right? It's coming up. All right, awesome, guys. Okay, next question. Okay, if Alex tests positive for H. pylori, what is the first line treatment regimen based on the most, and can you include them? Okay, include what are the first line, what's our first line? So I'm working off of two screens. That's why I'm not always looking at you guys. I'm looking at your answers on my other screen. Bismuth salt, quadruple therapy. Yep. Wonderful. So what do you guys remember what is all included in those? Treat my belly pain. So pepto and bismuth is the same thing. So treat tetracycline, my metronidazole, or amoxicillin. Okay. Belly is the bismuth salt and pain is the PPI. Remember, PPI is going to be in all of them. PPI, bismuth salt, tetracycline, metronidazole. Yes. And do you guys remember what I said for the acronym for the triple therapy? The triple therapy was pack that ulcer, so PAC. Pack. Add probiotics too. Yes. Good. You're doing awesome. Pack that ulcer. So we're thinking PPI, amoxicillin, clarithromycin. Okay. So the only thing we don't have in our triple therapy that we have in our quadruple is the bismuth salt or the pepto. Good job, you guys. Okay. Let's keep going. I just wanted to show you. So this is just a quick refresher. This is our quadruple therapy. That's our first line treatment as of now, according to the American Gastroenterology kind of association. I may be getting their name wrong. I'm sorry. But that is first line. Okay. Next question that I have. If Alex tests negative for H. pylori, what would you do? All right. So you did the H. pylori test, came back negative. What are we thinking now? Treat as an ulcer. Okay. What, any medication that you might PPI only? I love it. Good. Educate on alcohol use. Uh-huh. Do you remember what else he was using a bunch of that maybe we should consider educating him on and figuring out what's going on there? 2 months he said he was taking. Stop the NSAIDs. Absolutely. So let's address that back pain. Why are you taking the NSAIDs at, you're 29? That seems like pretty too much Advil. Absolutely. Yes, 100%. Well, go ahead and treat his belly pain. Um, it's not H. pylori, so we assume that it might just be GERD, or he could have just an NSAID-induced ulcer. So in that case, Celebrex is a better option, right? So Celebrex is just the COX-2 inhibitor. If I'm getting that right, I could be wrong, but ibuprofen is a COX-1 and COX-2, so it has more effect on the GI, whereas the COX-2 is just more local on those muscles. So, and I might be getting that just a little off, but something around that. Okay, good. Um, so, we are going, oh, somebody else is typing. Go ahead. I love that you guys are participating. This is so great. Okay. I'm just going to move back. So if we didn't think that there was something else going on, we could consider if he just had GERD. If we thought it was just GERD, we could go ahead and just do a PPI for 8 weeks with a slow taper. You could do an H2 blocker, but that's going to be a little bit less effective. So just one kind of option that we had there. Okay, and next up, what lifestyle modifications? You guys really covered this in the last one. And I think that you guys did really awesome. We can kind of go through. I'm going to show you what I put for lifestyle modifications. The NSAID and alcohol, we would always consider smoking cessation if applicable. Obviously, with him, it wasn't. The other thing we can do is tell folks to eat small, frequent meals to kind of help if they had something like GERD or an ulcer. Okay. And then weight loss is always something that we also want to consider. Okay, I've got more questions. Keep them going here. Our next question, how do PPIs compare with H2 in managing GERD? We kind of talked about that a little bit. Tell me some considerations between the two. Let's go. Oh, sit up after eating. I liked that. Good job. Oops. Yeah, when you think of these two medications, any differences that you can think of, even in their pathophysiology and their indications and their contraindications and their things we should be kind of cautious about, side effects, long-term side effects. PPI is stronger, absolutely. Remember, it does that irreversible binding. PPI shuts down the pump. Yep. So it's going to work. It's going to really make us with a low acidic content. Also costs less out of pocket for over the counter. PPI takes longer to kick in. Yeah. So I typically think that it does, and I educate my patients about that it does take a little bit longer to have the full effect. Whereas that H2 blocker, I think within 30 minutes of onset, we should start feeling an improvement. PPIs, we say they don't hit their maximum effect until about 2 weeks. So yeah, definitely takes a little bit longer. You'll notice some effects right away, like within the first few days, but the full effect is going to take a couple of weeks. Yep, H2 works quickly. CNS effects with H2. Yes, I'm so glad you remembered that. Awesome. Because that's an important one for boards, especially if you haven't taken your boards. Just elderly. If you have an elderly patient who comes in, has acid reflux, we're going to a PPI for multiple reasons because we're going to treat it a little bit more seriously. In an elderly patient because if they're having acid reflux, they're at an increased risk of complication from that. But that H2 blocker, we're going to use precautions when prescribing. And if we can choose something that doesn't have central nervous system effects, we're going to go that route. So absolutely, good job. Okay, I have this table here with just some of the differences here. If you guys want to take a quick photo, but my takeaways here, PPIs provide stronger, longer lasting acid suppression, are the preferred treatment for peptic ulcers and severe GERD. H2s are really useful for mild intermittent acid related symptoms due to tolerance development and weaker acid suppression. Okay. So I would say if it's severe, if they're elderly, go for your PPI. Awesome. Whoa, okay. We are just about done here. Okay. When should we consider sending somebody to get an endoscopy or a referral? Like, what are some red flag signs or symptoms? If Alex told you, you'd be like, I'm not going to deal with you here in primary care or urgent care, wherever you're working. I'm worried about you. Okay, an 8-week failure. Good. Like that. Anything else that really bloody stool? Yep. 100%. Some other red flags. Excessive diarrhea, vomiting, family history of cancer. Yep. Stool changes. 100%. Yeah, that early satiety. So like you get full really fast, or maybe like if you did a physical exam and you didn't feel any or couldn't hear any bowel sounds, right? If we thought there was an obstruction happening, severe pain, absolutely. Good. Yes. Weight loss, night sweats, extreme excessive gas. Yeah, they're just really uncomfortable, lots of bloating, 100% tachycardia. Yeah, if you're thinking tachycardia, tell me what you're thinking. I'm curious, just to kind of help each other learn. Rigidity. For somebody's tachycardic and they have really bad abdominal pain, trouble swallowing, absolutely. Dysphagia. Whoever said tachycardia, tell me what you're thinking. What are you thinking about? Barrett syndrome? Mm-hmm. Thinking about a GI bleed with all of these symptoms too, right? So just things to look out for. Anemia, yeah, we could see anemia. Absolutely. Yeah, if somebody is anemic, he's young, he's anemic, he's got severe gastric pain. Definitely worth looking into. Okay. Um, oh, somebody else is typing. Yay. I love it, you guys. This is so awesome. Saliva changes that are sticky. Heart rate may go up with anemia. Absolutely. Yeah, so your body's just trying really hard to get that oxygen through. And if we don't have those oxygen carrying cells, then it's gotta, you know, work its way. All right, so when to consider endoscopy, alarm symptoms, unexplained weight loss, dysphagia, GI bleeding, persistent symptoms despite optimal PPI. So you're doing all these things. or the persistence in H. pylori. Again, those alarm systems, complications. Okay, you guys got them. I think you got everything there. All right, and our last question here, when should Alex be reassessed? So let me just pull it up over here. When would you bring him back in? Okay, so let's go back to the H. pylori. We treated him for H. pylori. When are we going to see him again? What is our follow-up going to look like? Sorry, we are a little bit over, but as long as you guys can hang around, I can hang around. 8 weeks. Yep. 8 to 10 weeks is typically when I bring people back in. If you're really worried about them and you're a little worried about medication adherence, I think if you could implement like telehealth, just a quick check-in, like a couple of few days after they start those antibiotics, because you could have somebody who has such severe antibiotic reactions, like their stomach hurts and it just feels worse, and they might question your treatment when they start taking as many antibiotics as they have to take. So I think a 2 to 3 days, like maybe just a phone call check-in or a telehealth visit, if you have that capability, can be really, really beneficial. And then we're going to get that test of cure, right? And we're going to make sure that they're off that PPI for at least 2 weeks before we do that test of cure. But yeah, I think you guys are 100% right about how we're going to follow up on this. Okay, my last questions. These are no, we're done with the case study. Did you guys have any questions here? Oh. I would like to kind of assess and make sure that we're giving you information that you want to know about. Do you guys have any topic ideas that you would want us to cover in these weekly webinars? Any new ideas? We love hearing from you. It helps us kind of get some information. Professional issues. Okay. Awesome. I'm going to write these down. This is always helpful for us because we create stuff. Cardiac rhythm strips. Okay. Yeah, we do. Kiva, our director, is amazing at EKGs. So we'll definitely get EKG back on or ECG, depending. ECGs, professional issues. Anything else? Antibiotics. Yep, we hear that one a lot. We need to create an antibiotic lecture. I think we have one, but let me just bring it back out. Test success tips. Okay, just testing tips. Do you guys do any of you ever do the rapid 30s where we just go through questions? How does that feel, just doing the rapid 30s? So we just spend, an hour going through test question after test question and how we analyze it and answer it together. It would basically just be a Slido presentation at that point again. Writing clinical notes legally. Okay. Yes, Kiva is the bomb. Oh, I gotta take a photo of that and just send it to her. I love that. Okay. I'm gonna send that over. She is so great. Yeah. So if she has any of those lectures, I really encourage you guys to get in. I learn when I hang out with her. Okay. And then writing clinical notes, what you need to include. I actually just had I work on a public health bus, and I had my director come in and she just showed me her notes and how she writes her notes. She's an MD, I'm an NP, and the difference in our notes and how much more I've been practicing for 5 years, and I thought like, oh, I've really gotten it down pretty narrow. And she was like, your notes are beautiful, Morgan, but we don't need so much information. And she just like gave me her template, and it was really narrow. And I think as nurse practitioners and as nurses, typically we like to include a lot of detail, and sometimes it's not necessary, and it can really get into our work-life balance. So I think definitely if you're mentors, if you have an opportunity to see how other people are writing notes, look through people's notes. If you really look up to somebody as a provider, I think that's a great idea. Okay. Template sharing and guidance to make us efficient. Okay. We can like look through some templates maybe for notes. Yeah. So cool. NP charting school website. Awesome, guys. Okay. And did you all like Slido? That's my last question. Oh, insurance. Yeah. Oof. Coding, billing, and coding. That's a big topic. I think, let me, That is a big topic. I feel like I'm always learning new things. We have to do all this stuff. Okay, in 0 to 10, how did you guys like using Slido? How did you like today's webinar? Did it feel helpful? 100%. Yeah, good. I think it makes it more interactive. It makes it more fun for me, I guess. That's a very selfish way to look at it, but I feel like I actually have people that I'm talking to rather than just to the, outdoors. It's what my office looks out over. The Rockies is pretty here. But okay, you guys are awesome. Again, if there's anything that you needed clarification on from today's webinar, feel free to reach out. You have our email right here at nursepractitioner@archerreview.com. We love hearing from you all. So just let us know. And then again, if you're not already, if you need some help getting through your exam, we have awesome products. Okay, this is really, really great. It's a sure pass guarantee. And I mean, that's great. And it's, I think we come at a pretty good price point. So definitely take a look, you guys. We have some really great products, and we just really want to help nurse practitioners feel really confident moving, sitting for their boards exams and moving into that next arena. All right. Well, that wraps up today's webinar. I hope it was helpful. It was fun for me, as always, and I look forward to seeing you. I am presenting next week on menopause, perimenopause in the primary care setting. So if you are available, come and join me next week, same time, same place. And I look forward to talking with you guys again. Have a wonderful rest of your day. Oh, somebody asked something. There are a few sites that were unfinished. Okay, sounds good. Somebody sent me a Q&A. Is there anybody that you could just write an email for me? That would be great. All right, I really appreciate it. Everyone, have a wonderful day, and we will see you hopefully next week. There's probably some other lectures this week. I don't have them all written down, but with some of my colleagues. So, guys, best of luck to you in your journeys, and we'll talk next week.